So Corinne is the Executive Director of Continuing Care with Alberta Health, where she leads policy development for the province's continuing care system. She has a Master's of Science in Gerontology degree and a Master's of Public Administration, and in 2008 was inducted as a Fellow of the Canadian College of Health Leaders. Corinne is passionate about improving the quality of life for seniors. She has over 30 years of experience working in senior leadership roles in the field of gerontology in Alberta at the provincial policy level and with seniors service provider organizations. So thank you, Corinne. I appreciate you stepping in on Evan's behalf, and I'll hand it off to you.
Great, sounds good. And thank you for asking us to just give you an update on some of the things happening in continuing care. Dana, before I start, what's the time that we have allocated to this?
We have we have a lot of time. Actually, we're running ahead of time, Corinne. So we had allocated about an hour, which includes the presentation and some Q&A, right. But we do have additional time if you have time to stay and if there's questions from the floor.
Okay, sounds great. Okay, thanks. So this is kind of an overview of lots of different things that are happening in the continuing care arena. And so kind of an update on what's happening on the government side of things to strengthen the system. So if you could advance there. And there we go. Yeah. So I don't think this audience really needs too much introduction to the system. But just to remind everybody, when I'm using the term continuing care, it's not specific to one sector. It includes home and community care, includes supportive living accommodations such as lodges, includes continuing care homes. We're using that language these days, which would be long-term care, as well as designated supportive living, and includes palliative and end-of-life care. And you can see the different costs per person per year there. So in terms of directions, you can see where we need to really focus on really expanding in the home and community care area. Next slide, please. In terms of governance, so I'm speaking on initiatives that involve mostly Alberta Health and Alberta Health Services, but just to remind people of different roles. So Alberta Health is the legislation and strategic direction, and then Alberta Health funds AHS and some capital as well, but we don't do the operating of programs. So people often get AHS and Alberta Health mixed up. Not this group, I don't think. And then we monitor system performance. We set accommodation charges. AHS actually does the delivery either themselves or through contracted operators, develops operational policy and does the actual funding. So funding methodology and so on is the AHS side of things. There's also a role for community and social services, particularly with people with developmental disabilities and some of the housings side of things, as well as income supports for people under 65, low income, and then seniors in housing, of course, we work very closely with, who run the Seniors Lodge program. Income support programs for seniors. Elder abuse is a big focus of their area, and they work collaboratively with some of the community-based sector organizations. Next slide, please. So in terms of challenges in the continuing care system, we have the population aging, and so demands are always growing. Right now, Alberta has about 700,000 seniors, which is about 16% of the Alberta population. We will be dramatically increasing that. In fact, Alberta has the fastest growing seniors population. We will have doubled our seniors by 2046 in about 25 years. And of course, most of the healthcare costs are attributable to a very small percentage of the population, and 3/4 of that small 5% population are frail elderly. So, so it is a population that we need to be very aware of in terms of planning ahead. Next slide, please. Our system is complex, and every time we add something new, which we always like to do, we add to that complexity in the system. Um, I'll speak a little bit to the facility-based continuing care review, and it really flagged and heard from people about the complexity of the system, the need for navigation supports for the public. We will talk a little bit about the workforce, which I know is your key area of focus, and that's one of the systemic issues, and that after COVID, this is worse than ever. Sustainability of the system is critical. Since most of the system is government funded, and right now with the high inflationary costs being faced by continuing care operators, such as many of yourselves, we're hearing this more and more. And we know that with the aging population, more and more people want to stay in their own communities. But the Alberta government, public spending, the proportion of our spending in healthcare on home care is actually lower than other provinces. So we've got a lot of room to grow there when you see the comparisons there. Now, next slide, please. So workforce. Demand for staffing is high and our supply is limited. One of the issues here is education training costs. The costs are pretty high compared to the opportunities when people get out. So that includes full-time opportunities that are limited. That also includes pay issues. So we've got pay issues of inequity between even within the healthcare system, with hospitals paying more and then continuing care homes paying more than home care. Continuing care is not necessarily seen as a desirable place to work. I just was talking to one of my workforce colleagues this morning who said they'd had a meeting with all the post-secondary institutes yesterday. And the post-secondary institutes were saying, you know, their enrollment is down, and B, when the students come back, they're saying, I don't want to work there. People are exhausted, they're miserable. So it's we're having the issues that we have are building on themselves to make it a perfect storm here. And so this is going to be a really key issue going forward. I'm interested to hear more from your organization, from those of you on this, as to what we really need to be doing here. We know the demographics, mostly this is healthcare aides in continuing care. We know that the majority of them, 2/3, are 40 years plus. And their bodies are probably more than 40 years plus if they've been working at this for 20 years or so. And 61% have English as a second language. So all sorts of complications here that make it a real challenge in this area of work. And that's not unique to Alberta. No, go ahead. Thank you. Workforce conditions, very difficult. In home care, we've got the additional challenges such as travel time, working alone almost all the time. And so we have higher turnovers and injuries, and which you will know better than me. We've got increases in terms of the needs of residents. Some of the data that we have, recent research done by the TREC group out of the University of Alberta that some of you may be familiar with, translating research in elder care, led by Dr. Carol Estabrooks. No, if you can go back to this, there we go. Some of the data that they found were that 65% of staff reported that they have to rush one essential task per shift, and over half say they just entirely miss at least one essential task per shift. And these are really essential tasks. These are not doing somebody's nail polish or anything like that. And we know that at least 30% of staff are working multiple sites in order to get to a full-time position. Next slide, please. So COVID highlighted some of our existing issues out there. Those included social isolation and mental health challenges for seniors as well as their caregivers, both in the community and in continuing care centers. We know this is going to have an ongoing impact. We just don't know how long and what that's going to look like. In terms of older buildings, Alberta fares better than most provinces in terms of proportion of private rooms, but we do still have a large supply of older buildings where there's shared rooms, and that definitely accelerated the spread of COVID-19. Where Alberta has fared better is that Alberta has provided more capital grants than other provinces do to private operators, including nonprofits and for-profits. And by providing those grants, we were able to specify that they would only build private rooms other than for couples or people wanting to share. So now going forward, we really want to focus that capital funding on replacing some of our older sites. And then some systemic staffing challenges, including the differentials in wage rates, lack of full-time positions, and so continuing care operators finding it very difficult to recruit staff at present. That's not unique to this industry. Treasury Board has done surveys across industry-wide beyond healthcare, and that is something that business owners across the board are finding actually in the province. Next slide, please. There are some good things happening, and so we always have to remind ourselves of that. We have a great foundation in many regards to build off of and to improve the system to meet some of those challenges and demands. One is that although we hear a lot about private for-profit in the news, anytime we look at the outcomes of care in our publicly funded sites, it doesn't matter what the ownership type is, the outcomes are similar. And I think partly that's because we have in Alberta consistent standards. So everybody has to meet the same standards. If you're publicly funded, you need to meet the continuing care health service standards as well as the accommodation standards. That's not necessarily true in other provinces. And we fund at the same rates. And so everybody has the same opportunity and there's the same expectation and accountability for outcomes in this province. So we don't see the variability across ownership types that some of the other provinces do. Another advantage is the Alberta Seniors Benefit Program, which has the highest income thresholds and some of the highest benefit maximums compared to other provinces. And when we look at seniors who might be in care facilities, we have, there's any senior and anybody on AISH can afford to live in a continuing care facility. There's no barriers for income because everyone is guaranteed $322 a month leftover income. Government will make up any supplement and supplement any income that's short of that. Another advantage is the ward room. So in the beginning of the pandemic, we heard a lot about the crowded conditions, the number of deaths because of crowded conditions. Alberta no longer has any ward rooms, so those have been eliminated last year, and that was one of the recommendations coming out of the facility-based continuing care review, is that we close all of those, or at least not admit more people into, so they are now at the most semi-private rooms. So Alberta does not have those ward rooms anymore. I heard a ding, but I'm not sure if that was signaling me. And then I would say the other thing that we have is a well-established continuing care system with very strong historical partnerships among government, industry, and Alberta Health Services. And during the pandemic, that was even more so, where every policy decision that was made during the pandemic was worked through with the stakeholders. And we had daily meetings for quite a long time. Fortunately, we've gone to weekly now, but that's still a very collaborative approach to any decisions coming forward. So you can go ahead with the slides there. So just to talk about what we're calling continuing care transformation. So some of the progress so far, one, since 2020, even though the ongoing focus has been certainly keeping people safe during the pandemic, there have been some significant gains during that period as well. One is expansion of palliative support, and a specific example of that was including coverage for the costs associated with pre-filling syringes under palliative care coverage programs. So that is no longer something that people need to pay for personally. We have expanded public reporting. So as of July of last year, the continuing care health service audit results are now reported publicly. So that's a promise for more transparency to the public. And so that happened. As of March 31st of this year, so 3 weeks ago, the continuing care facility directory, which is hosted by AHS, was expanded at the request of supportive living operators to include supportive living sites. So those are now included there. And so again, to help the public with transparency and with navigation of the system, we have continuing care design standards being developed. And I'll come back to the capital program for Indigenous continuing care, but that went out in this past summer, and the results of that will be announced in the next few months. So in terms of investing for the future, go ahead to the next slide there. Budget 2022 was a 6.3% increase for the whole area of continuing care, including home care. There is 20 million budgeted to improve access to palliative care, as well as a significant amount of capital funding for modernizing continuing care facilities and adding some capacity to the system. And in addition, we have 24, or if we include all the AHS sites, continuing care sites would be 26 million per month that is continuing to go to continuing care facility operators to support them with staffing, extra staffing during COVID, as well as protections for health and safety, such as PPE and some of the cleaning requirements. Go ahead to the next slide. So for when we look at continuing care transformation going forward, this is a very complex undertaking. It requires careful planning. It's going to take months. It's going to take years ahead. The facility-based continuing care review report had 42 recommendations. We can't implement those overnight. But those initiatives under this are anchored under 3 areas. The first and foremost probably is expanding home care. We can't move forward with all of our directions without dramatically expanding the number of people who are getting receiving home care. This is kind of a win-win one. We've always said this, and everybody's always said this. It'll achieve cost avoidance over time, and it's what people want. Pillar B is improving our workforce capacity as well as supports in the environment for staff. And the third is improving quality of life and care for continuing care clients, residents, and their families. Next slide, please. All of the transformation initiatives are coming out of engagement with the public and with providers and organizations like yours. We did targeted engagement around the legislation, the continuing care legislation, asking what needed to be changed. Just a little over a year ago, we received written submissions from 33 stakeholder organizations, so very extensive written input into that. The facility-based review I mentioned, that report was released last May. We had over 7,000 respondents from the public and other stakeholders, 90 interviews that went into that report. Also last year, an MLA-led review of palliative and end-of-life care. Despite COVID, able to have over 35 engagement sessions. And then on an ongoing basis, we have our what we call the Provincial Coordination Committee. That group meets weekly on COVID-specific specific issues, although those COVID issues get broader and broader, such as workforce, etc. And then we have the Continuing Care Alliance, which is a broader stakeholder group that we bring all of the policy thinking and directions to for feedback there. And so I'm not sure if we actually have the CCSA on that. Certainly you'd be welcome to join that if that's anything of interest there. Next slide, please. So legislation. The Nursing Homes Act was introduced in 1985. Right now we have 6 acts, 6 regulations, and 3 sets of standards that cover continuing care in this province. And so clearly it's outdated, it's fragmented between all of those sets of standards and regs and acts. It's quite restrictive in what people can do. And that was kind of the tenor of the day when government really didn't have any other way to look at what is quality. So it made really restrictive requirements. That's not really the thinking in legislation today. There's inconsistencies, as you can imagine, when you've got one piece of legislation that was set in 1985, another one came in 1990, et cetera, et cetera. Between sectors, you've got I mean, just as an example, client benefits are different, dependent on whether you live in DSL or long-term care or live at home. We know that there were some issues with inspections and audits and so on, and just some plain gaps. There is no legislation covering designated supportive living or palliative care or hospices out there. So something needed to give there. So next slide, please. So as you probably know, Bill 11, the new Continuing Care Act, was tabled in the legislature on March 28th. So it's not even a month ago now. So pretty hot off the press still. This is overarching framework legislation. So going back to what I said about less prescriptive, that is the direction that legislation is going now, is to have legislation that enables directions, but doesn't restrict as much. And so the bill will establish clear and consistent authority. So we need to have clarity around who's responsible for what, who's responsible for overseeing, for licensing accommodations and delivering. The act itself is only the first stage. There will be a suite of tools, and so additional requirements will be enabled through developing regulations, through revising and updating our standards and policies, and this will begin to get implemented next spring. So the bill has gone through first and second reading, but it will not come into effect, if it's assuming it's passed, until next spring, because we need to have some more flesh around the skeleton. And so what we're really working on right now is the regulations to accompany and provide some specifics there. If you can advance to the next slide. Some of the outcomes that are intended there with the new legislation is to eliminate some of the barriers we have right now. So there's actually barriers to aging in place in our legislation, and some of them have to do with the benefits available with people. If you get more benefits when you move into a more restrictive setting, that means that you can't afford maybe to live at home if you've got more cost to live at home. Residents in continuing care centers are often required to move locations to receive a higher level of care, even if that care is available on the same campus or even sometimes on different floors in building. We also know that couples and companions with different care needs are often unable to remain living together, and some of those things we need to operators have addressed at the local level, but we need to address through legislation. And current legislation also causes barriers to implementing some innovations and different models of care, such as one example might be the small homes that are recommended in the facility-based continuing care review. So one of the outcomes is to eliminate the barriers. Another outcome is to enable a more person-centered, a more flexible system, to improve transparency and accountability, to align the services and requirements across, so that we don't have one requirement in one sector and another in a different sector, and to reduce red tape where it makes sense, by replacing multiple existing acts and regulations with a streamlined, updated legislative framework. Next slide, please. In the preamble of the Act, which we don't have in our other acts, one of the things that's been put in there is it's just you can go and read it. It's actually the Act is now online. The preamble talks about the principles, and although this isn't the rules and the enforcement piece of things, it really does talk about what are we trying to do? What is important to the continuing care system? What are the concepts that we want to reflect throughout the new legislative framework and that are foundational to other transformational initiatives underway in continuing care? And so quality of life being first and foremost, along with person-centered care, respecting the diversity in the system and recognizing the importance of staff and of caregivers themselves, enabling aging in place, aligning with other services and healthcare, and then of course dignity and respect, taking into account people's physical, mental, spiritual, cultural needs. And so that preamble, although it's not the regulatory piece of things, I think is a very important thing to point to, because it really talks about where do we want to go. Next slide, please. So I mentioned that the current focus now is on developing the regulations, because that's where the meat of things is going to go. The current regulations on the left-hand side, you can see there's 6 different sets of regulations that we'll be putting into maybe 2, don't know exactly at this point in time, 2 sets of regulations. And we are looking at a variety of topics there. If you go to the next slide, the policy topic areas include quality and access. So that would be content that ensures the provision of safe, high quality services that's focused on quality of life. So that would be things like admissions, assessments. What do we need to put in there around resident and family councils? Other topics such as standards, room types, and so on. So that would be things that would be in the quality and access. In terms of services and fees, this would include what's in that basket of continuing care services. What are the fees and charges? So we have them now. So just being very clear and more consistent across the system on what do people pay for, what services might be eligible for a co-payment. And so this is where, of course, accommodation charges might come in, pharmacy services, resident property and trust accounts as examples. Staffing and case management is, of course, a great area of interest. And so this is going to be determining how much do we actually put in regulations to support high quality care. So in terms of staffing models and levels, the types of staff, coordinating and care. So we're just going through that process right now, working with our stakeholders on that. And then fourthly is topics around compliance and monitoring. So oversight, accountability, enforcement measures and processes. Those of you who may have looked at the Act, you will see that there is actually more rigor in the Act around accountability. For instance, going from fines, which are right now up to $1,000 a day, to the new Act has up to $100,000 a day of fines for breaching requirements in the legislation. Now, obviously, that wouldn't be the first step in anything we'd be looking to, but it does say we're taking this very seriously, and some of that is coming out of learnings from COVID as well. All right, next slide, please. So as we look at implementing this whole legislative framework, as I mentioned, the Act was introduced on March 28th. It will be in effect when it's proclaimed. And we are right now, spring, summer, looking at the regulations, lots and lots of meetings with stakeholders to look at the regulation content and hear from them about what we can do in terms of implementing. in the fall, at the earliest, it would be this fall where the regulations would be approved by cabinet. We certainly will be implementation planning with the new act and regulations in effect at the earliest next spring. At that point, then some or all of the existing legislation would be repealed and multi-year implementation would start there. It'll take several years to implement all of the pieces of the new legislation. During that time, we'll be reviewing our existing standards and developing new standards, looking at, are there some things that we can get rid of there? And undertaking a number of very important transformation initiatives that are independent, but maybe facilitated by the legislation. That includes things like funding model development, really looking at that, looking at some staffing expectations, expanding access to home and community care, and so on. And so we've got a number of years of work ahead of us and appreciate very much the support of the Continuing Care Safety Association in that. Next slide, please. So just kind of strategically overall, again, the Act is framework legislation. It's high-level requirements for the system that'll take multiple years to implement. And the system shifts are reliant on a number of other actions, including actions coming out of the facility-based, the palliative review, home and community care initiatives. And as we work on those, as we build that, we're going to continue to work with key stakeholders on that. Next slide, please. So just a little bit about the facility-based continuing care review. That report is available online. It focused mostly on DSL and long-term care, aiming to include learnings from COVID to modernize the model and increase residents' quality of care, as well as quality of life and staff well-being, as well as increasing transparency to the public, accountability and efficiency. And so right now where we're at is that far right box, which is action planning and some early implementation that's underway. Next slide, please. The report, as I mentioned, had 42 recommendations. Those were under 11 policy directions. I won't go through all of those directions there, but you can see them on the slide there. But focusing on, first and foremost, resident quality of life. And you can see a lot of those themes there that I've spoken about, even as we look at picking up some of those themes in the continuing care legislation. Next slide, please. So where are we right now in terms of the facility-based review? Well, some of the recommendations actually were immediately implemented. One of them was direction to support couples in continuing care facilities to remain together. So working with AHS on that. I've mentioned the enhanced public reporting on inspections. That was one of the recommendations of the report and was implemented July 1st of last year to have those audits online. We immediately phased out the ward rooms and are now planning, as we develop the capital plan, to continue phasing out shared rooms. We are working on updating design guidelines, including some of the learnings out of COVID. Providing capital grant funding to Indigenous groups was one of the recommendations, and expanding community care services. And so those are a few of the recommendations, but there's also work underway to identify what are the other recommendations that we can work on immediately as part of continuing care transformation. And all of this is a matter of what are kind of the foundational things that we work on, because we can't do 42 at once. So what are the first ones that we need to really focus on? Next slide, please. This slide talks about the modeling that was done in the facility-based review that is much broader than facilities. And so what this shows is if we move, so right now, so the pillar, the bar on the left-hand side shows our current distribution of clients across the continuing care system. So if we add together all the clients who are receiving either home care or DSL, long-term care, 61% of those clients receive their care through home and community care. So that means 39% are in a continuing care home. What the facility-based review report modeled was a shift to, by 2030, which isn't that far away now, gets closer and closer every day it seems, shifting to 70% of clients getting care at home and 30% in continuing care homes. If we do that, an additional 10,000 people over and above who would otherwise be in facilities would be receiving care at home. And so that's quite a dramatic growth in our home and continuing care services. Next slide, please. So how are we going to do that? So this year, just starting the two priority areas in terms of expanding access to home care. First of all, one is an expansion of client-directed care options. Again, a recommendation found in the facility-based review report. Edmonton Zone, as some of you are aware, had been doing a small limited pilot of client-directed care in which they were clients who needed respite services, could receive the funds for that themselves and then hire their own respite services. That's proved to be very successful. It's kind of a mini self-managed care program for those of you who are familiar with self-managed care. That requires quite a bit of administrative work. And so this was a mini version of it and a lot of satisfaction for clients. And so as of April 1st, so just 3 weeks ago, we have developed with Alberta Blue Cross a system where clients can just like you go to the dentist or your pharmacist, bill that through Alberta Blue Cross. AHS will fund those services on behalf of the clients who've been assessed as needing that, and you've got a full system in place for vendors to work through. So we're starting in Edmonton since they already had that pilot going. Calgary's planning to get going in July, and the other zones will follow that. So that's an exciting development. Just the first phase of more client-directed care. We're not going to go just stop there, but that's the first phase. As you can imagine, setting up the whole administrative system with Alberta Blue Cross was pretty complex, and they've gone to a ton of work of putting in place the information system and billing systems required to do that. The second big piece of work that's going to happen in home care this year is the updated vendor procurement. So the last time that the home care contracts were last time there was an RFP for home care contracts was 2013. And then the contracts have just kept being extended and then extended a little more and then a little more. So there will be planning to be an RFP or probably an RFEOIQ, which is an expression of interest, some version of that going out this year to address the expiring contracts. So they expire in September of 2022. And our hope is that those will not just be same old, give us a price, we'll buy that service kind of thing. But we really want to see some opportunities for innovation. And home care providers who work in other provinces have said, you know what, we're doing such and such and such and such in Ontario. We'd really like to see that there. And we really want to see this process expand the ability of home care to support people aging at home and make this the beginning of expanding from that 61% to 70% of people being able to receive their continuing care services at home. So those are the two starting points for home care being launched this year. Next slide, please. The second pillar, as I mentioned, is actually staff. And so human resource strategy is something that we're looking at. So these are the recommendations in the facility-based review. And so not all of these will be implemented this year, but some of what we're looking at is potentially a task force whatever it might look like, but a stakeholder group that would come together and really look at a human resource strategy for continuing care, which might include wage alignment, might include consistent staffing. What are the workforce improvements? So that could include hours of care, staffing hours, the whole area of casual staff. So what are those things that will help us with our workforce here? Educational subsidies as well. That's one of the factors that we're putting in place. That is actually an initiative that we're looking at. Actually, I think let's go to the next slide. And some of the initiatives that we are looking at there, we do have let me just look through this, all the bubbles here. So healthcare aid incentives and training. So being rolled out, and there'll be more news to come on this, but we have invested $13 million this year in providing healthcare aid bursaries to try and get the number of people enrolling in the schools, to try to increase that, to try and reduce the costs of training to those students, so that they don't come out with debts and then go into a scenario where the wages are hard to make up those debts. So that's one initiative specific to this year that we are rolling out. It's not going to be the only thing. And again, we are hoping to have some sort of a task force, et cetera, that will advise us on what are the other strategies that we really need to look at implementing to look at our workforce. Just another thing that I'll mention is a research that partnership that we have with, I mentioned the TREC team earlier. So we've given them a grant to look at the health workforce in continuing care. And there might be some, I think, partnerships that might make sense with CCSA on that. I know that you've got some really valuable information on the workforce that perhaps we could pull into that research that's underway. Go ahead to the next slide, please. And that's the third pillar, which is prioritizing quality of life and improving the quality in the system. Most of this won't come this year. We're focusing this year on starting with the home care, as well as looking at the workforce, but we will be looking at improving our standards in terms of really focusing on quality of life. We are hoping this year to begin the process of increasing the average hours of care. We are still bringing forward a proposal to government on that, but that's been developed and we'll see where that goes. And then, as I mentioned, the enhanced system accountability, streamline inspections and monitoring, that work is going forward this year. So that one is moving forward. So there's something on each of the three pillars that's already moving forward this year. There's, of course, we have to be mindful. We are still in a pandemic. We are very aware of that, working with providers. And so the amount that the system can absorb at any one point in time is limited. But having said that, if we don't move forward on some of these things like increasing average hours of care, we don't address the issues such as staff fatigue and turnover, et cetera. So we really do need to move forward on some of these. Next slide, please. In addition to those three pillars of transformation, we are also moving forward this year on improving continuing care infrastructure. And so some of the things that we'll be looking at are supporting small homes. I'll come back to that in a minute. I mentioned replacing the older infrastructure. So the $204 million that is over 3 years that's in the budget, a lot of that's going to go to older infrastructure as opposed to expanding spaces. Looking at, as I said, eliminating shared rooms as we move forward with that. Trying to look at partnerships with not-for-profits as well as for-profit providers, which Alberta has always done. We've always had partnerships in the system with all of our providers. That's not going to change. It's not going to go anywhere. That's the same in every province. We've about a third of our facilities that are public for-profit, a third that are public sector, a third that are publicly funded but not for profit, and a third that are publicly funded and for profit, approximately. I mean, those proportions go up and down with facility openings, but we have a pretty good balance in our system, and it's worked well for Alberta. So later this year, we will have, actually, if you go to the next slide, a grant process, a capital grant process that will be coming out sometime in 2022-23 for modernizing in a few priority communities. We've got the grant stream for the Indigenous communities, which is something that I'm just really excited about. This is a first in Canada initiative to actually reach out and say, to our Indigenous communities, which are often very remote, rural settings, where people have told us from those communities have said, look, this is the generation that grew up in residential schools. They had to leave their reserves, their settlements, when they were children. They're finally back, and they get older and they have to go away again in their older years and live away again from their home communities. And so this grant stream is particularly to try and address that. We had a very good response to our call for proposals here, and there'll be some announcements coming out in the next few months. And as part of our overall modernization grants, a new priority will be including small homes. So whatever small homes might look like, maybe 14 or fewer, 12 or fewer, looking at what that might look like and whether that is a separate call or included in the overall capacity building call overall. Next slide, please. So that's the facility-based review and some of the capital. Just to mention as well very quickly, but also last year there was a review of palliative care, and that report is available now online, the findings from that. Those recommendations that are in there validate work underway in the province that some of you may have been involved in back in 2014 when the AHS and Alberta Health worked with stakeholders to develop the provincial palliative care framework, and was updated last year in 2021. Next slide, please. And so that there's a commitment that was made actually as this government's platform to spend an additional 20 million over 4 years. And there was a call for proposals that went out in November. And those announcements are expected very soon. We had 125 submissions to that grant fund, and the priority areas of focus are those that were identified in the engagement with stakeholders. And so there's the research and innovation, expanding community services, education and training for the caregivers, whether those are informal or professional educational opportunities, and providing earlier access to palliative care. And then just finally, next slide, to look at some of the COVID supports. It certainly was evident throughout COVID that residents in continuing care were among the most vulnerable, particularly before we had the vaccines. And so government has provided multiple supports to continuing care facilities and home care programs, palliative programs, to try and support people through this pandemic, including extra care staff. We had a comfort care initiative. We had benefits that were provided to staff, bonuses, $2 an hour wage increases. There was funding to fund practicums of healthcare aides, as well as bursaries for them, and that we're providing again. And then funding that has gone out to the operators themselves, and as I mentioned, has been continuing throughout the pandemic. And the last slide, I think, is just kind of looking at where do we go from now for COVID-19. We are working with our stakeholders to determine what's the best approach to transition away from some of the chief medical officer of health orders back into routine practice, not meaning that all of these would go away. That's not the intention, but rather than coming out with orders over and above, those will take a look at the experiences, the learnings, to determine what are those most effective public health measures that protect our residents, our staff, our visitors, but still support resident quality of life. And those will be adopted into routine practice through our regular standards and so on, rather than be included in separate orders. So I think that is it for the slides there. Yeah. So happy to hear from you, your suggestions and thoughts. And it looks like I'm going to move away from here and take a look at, see if I can get into the chat here. Did CCSA receive any of the COVID funding support? I don't think anything went directly to CCSA. It went to the operators themselves to support their staff. So that went directly to the operators. Is there thought given to isolation at home versus benefits? Naomi, can you maybe just expand on that for me?
Hi. Well, we're managed by a board of directors here in Green Acres Foundation.
Green Acres, okay.
Yeah. And I was just asked last night, actually, by my CEO, who it is that we should be approaching about the providing care at home and aging in place at home longer. And we were discussing the benefit of moving into a facility where there's a community feel. And because everybody knows, I mean, when my parents were alive, I didn't get over to see them every day because I was busy with my own family.
Yeah.
And so there's that isolation. Yes, they're getting cared for at home and they're in a familiar environment, but are they being exposed to the benefits that you would have in a lodge where your next door neighbors are always seeing you and you're always having conversations with other people, and there's not that isolation where you're sitting at home watching TV until your home care person comes to visit you and take care of your needs.
Yeah.
And so, you know, this industry has taken a big hit over during COVID with all of the negative press about outbreaks in long-term care sites and you know, the whole ball of wax. But quite frankly, until the province opened up and there were more people in community bringing in COVID to our buildings, our residents were very safe because we were having to follow all of the sanitization procedures and policies, and we had to follow the CMOH orders. And, you know, we contemplated in 2020 whether or not we should do a resident survey. And I said, yes, we do need to do one. And we've done one every year. And in our resident survey in 2020, we asked how safe our residents felt. And the percentage was high. I don't remember off the top of my head. In 2021, 98% of the respondents said they felt safe living in our buildings. So you can't really get much higher than that.
Yeah.
You know, so there's that whole concept. Our industry took a big hit because it was all negative press about the outbreaks and the number of deaths and the poor staffing levels. But that's not, you know, there might have been isolated cases of that, but I don't think the majority of the operators in the province faced that. The staffing shortages, yes, and we're still facing that.
Yeah.
But it's like our board of directors is now saying, you know, we need to do something, like we need to try and get more people in. But really, when home care isn't making the referrals to DSL-3 level of care and they're keeping people in their homes longer, by the time they're ready to move in, they're moving into DSL-4 or right into long-term care, which the move in itself is of bigger harm than moving them in sooner to a congregate living setting and having them exposed to that community feel.
Right.
And
Right.
the care that they get in a congregate living SL2 facility is just as good as the care that they would get at home, except that they have the benefits of having all these other people whom they form solid friendships with.
Yeah. Thanks, Naomi. Certainly, I think the seniors housing area has taken a huge hit. Ash is doing a very good job of advising us on that, as is your CEO. She's been very much part of all of our work. I hear what you're saying there. One of the things that we are looking at from through the home care, and I could have probably listed it as one of the things for this year as well, but is looking at going out to the, AHS will be looking at how to work with the congregate housing providers to expand those who are interested, and not all will be, but for those who are interested, to offer more in-house staffing for people receiving home care. So for those sites that do not have an in-house home care contract and have the external providers coming in and out all the time, which actually was an issue. A lot of residents were afraid of their providers, their home care providers coming in, whereas they weren't if they were staff in the building. So that's one of the things that we are actually asking AHS to do this year, is to say, to offer that to seniors housing providers who wish to have their own in-house home care program. And that addresses some of the smaller staffing positions. They can add that staffing to the home care dollars provided through AHS. So that's one thing that would help people to be able to age in place within those buildings a little bit. It's a bit of an aside from what you're saying. I understand your broader point, but hopefully that will help a little bit there. It's going to take some recovery time. Absolutely. We've been talking very frequently with our continuing care associations about that whole public perception now of congregate living environments. It's always so unfortunate. I mean, it's the media thing, right? But the sensational is what gets the news. And a lot of times the news was out of Ontario and Quebec, which have very different standards of care than we have in Alberta, very different standards of buildings than we have. And yet everyone paints everything with the same brush, and everything must be like that because we heard it on the news last night. Well, yeah, that was one place in Quebec, and that is a horror. That was a terrible scenario, but that doesn't mean that's happening everywhere. So, thank you, Naomi, for raising that. Other questions and comments? Dana, you can probably take us off presenting mode now, and then maybe we can see each other a little better.
Corinne, I just want to thank you for an excellent overview and background. Obviously, huge amount of work in terms of redesigning and moving a system forward is tremendous. Just a couple comments. One, some of the work you're doing with I'm not sure if it's the Trek Institute or GRU, is that focused both on workforce redesign in terms of nature and type of role, scope of practice, of actually looking at the design of the workforce being separate and distinct from the workforce planning priorities that everybody has spoken about? I just wanted to understand clarity. So there's two pieces. I mean, I always chunk it, and Blair, you have way more expertise in this area than I do in the HR area, but I always in my mind chunk it into workforce supply. So that's the demand, the get more people, and that's got to be about more than, wages is, I guess it is one aspect, but wages is only about moving people from one area to the other. So we're all competing for the same. So we got to do something around
increasing the supply. And so that's where we really need to focus on getting people into the training programs. Maybe that's immigration, so there's a supply issue, and then there's the workplace conditions. And so, as you say, workforce redesign. And so I totally think those are two different areas. I mean, they're related, obviously, but the redesign areas in the facility-based review, it talked about having maybe a target of X% full-time positions or higher positions, for instance. It talked about there were 3 or 4 workforce design things that they suggested in there. This is always an interesting area for government to dabble in, because is it government's role to dabble in workforce design? Is that, and so everybody's on one part of the spectrum on that. No, hands off my staff, hands off my business model, versus government, do something about this, fix this. And so that's exactly where we need to work with our operators on. But yes, TREC would be supporting the research end of, we have no data on this sector. I would say probably CCSA has the best data of any that we can look at, but it's obviously narrow and limited to your work. So that's kind of a starting point in this research, is going to be saying, who are these people? What are their needs? When I say these people, it's us. But who works in this sector? What do they want in terms of maybe they want, like, one of the things we found when we went to the single site was, and not surprising, but how many people were working more than one full-time job and wanted to work more than one full-time job. So we're saying, yeah, that'd be great if you give me a full-time job, but I'm still going to work at multiple sites because I want to work, I work all the time and I send home half my paycheck to wherever I came from, Philippines or whatever. And so we're not going to change that. That's, so what are the things, though, that government can influence in terms of levers that are government levers, that industry can change in terms of levers, and what are those supports we need to provide to industry? And so that's where I think, your group will have a lot of expertise and suggestions that we can take a look at. We need to really zone in on the evidence for what does make a difference. So, using the example of the workers who's already decided they're going to work more than full-time. Well, we know they're more prone to injury, et cetera, et cetera. And even if they get paid more, they're still going to work at 1.5. That's just, so we have to really look carefully at what are those appropriate levers. And sorry, Blair, go ahead.
No, I was going to say, certainly on behalf of the the CCSA, we will certainly be glad to augment on data or things like that builds the richness of the design and decision making from a strategy and policy perspective, because we are certainly in this together as a collaboration between the sector, the members, government, in that. The other thing, I probably sound like a broken record because I say it in several forums, but we tend to think about the workforce and how invaluable the front line is, which absolutely. But I think the other thing we have to be very cognizant of, how do we support leadership within this industry? Yep. People are exhausted and tired, and I think we need a very different strategy from an industry, from government potentially, to say, how do we build capacity and competence and with light at the end of the tunnel for people that, quite frankly, I think are burned out after the last 2 years.
Absolutely, Blair. Totally agree with you. And in fact, one of the reasons we funded TREC to move forward with some of this was they did some research on this during COVID, and I mean the results are heartbreaking. Like, I mean, if you haven't heard some of their some of the work. I mean, they're still working on it, but did some incredible work on interviews and so on during this period, and just looking at the leadership component and the amount of turnover expected. And I mean, this isn't news to you, but when you hear it directly in the quotes and so on, it's we have, for decades to come, I think we're going to feel the impact of this. So what do we do about that? Absolutely. Yeah. Thanks, Blair. You triggered me on something when you said, I was trying to take some notes to try and not forget. Yeah, I know. I was going to ask, so in terms of CCSA, some of the things, I'd be interested in just hearing a little bit from you on what do your data show during the pandemic, and it can be an aside conversation, but what are some of the things that you saw during the pandemic in terms of maybe change in kinds of claims, especially on the mental health end of things, costs, any trends that you saw? That was one of the things that I wanted to follow up with you guys about.
Would you like to do that offline, or would you?
Sure, either. I mean, if this group is all aware of it and it wouldn't be a good use of your time, then I'm happy to do that offline. Yeah.
Sure, Dana. I'm not sure how the time is, but.
Sorry, just a really quick comment, Corinne. It's LG from Capital Care. How are you?
Nice to see you, LG.
Nice to see you. It was actually a very interesting phenomenon we saw during our 24 months. We actually saw a decrease in sick leave. We actually saw a much stronger commitment, and we saw people running towards the fire as opposed to running away from it. And although, there were the majority of our absences were attributable to people who were close contacts or who were symptomatic themselves for COVID. So it was interesting. We saw quite a difference in the types of absences, but we did see in general illnesses and casual illnesses, if you want to call it that, a decrease, that most of our absences were related to COVID.
Interesting. Yeah.
Symptoms. So
the
only other one comment I wanted to make really, really quickly is your focus on workforce and hours, and more hours for employees, and having 2 FTEs as opposed to 1. The flip side of that is really looking at the number of hours of care. I know you're looking at increasing the number of hours of care, and hopefully the dollars will follow that. Because if the dollars can follow that, I think some of the workforce issues will be taken care of. I think if we really focus on what our resident needs are, I understand that perception of leave our business model alone, we'll take care of our staffing. If I can use the cliche, show us the money and we'll use it on how we staff and provide quality care to our residents. So I think the really important thing there is the number of care hours that our residents receive.
Yeah, absolutely with you, LG. And we're really, really pushing on that one. Absolutely. I agree with you that anything we can do to increase the hours of care will, those stats earlier about the number of missed tasks and so on. I mean, if you can give some more care hours, then obviously that's going to help a lot with that.
Follows,
yeah, absolutely. And yeah, you can't require more care hours without more funding. That's ridiculous. So yeah.
Thanks for joining us today, Corinne. It's been very helpful.
Thank you.
Okay, we have only a couple more minutes left, and just Corinne, I will follow up with you separately on the data that we have available.
That'd be great.
So
Thank
I'll follow up directly after this meeting. Don't want to take up any more time if there's questions from the floor for Corinne. I'm not seeing any more hands raised or any questions coming through the chat. So Corinne, I really appreciate you stepping in to share this information with our members today. Very interesting aspects, and I'm pleased to hear that you are looking for the CCSA and our industry to join in those conversations. So definitely we will be engaging with you as you move forward.
Sounds great, and thanks for the invite, and thanks on behalf of Evan. He certainly would have loved to have been with you as well, but I will let him know some of the conversation we had.
Awesome.
Thanks very much.
All right, thanks everybody. Take care.